Yes, it is okay now.
Is it visible now?
Yes.
Okay. So for this post-lunch session, IAD symposium, I would like to call Dr. Srinivas Murthy sir from Bengaluru and Dr. Parikshit Goswami from Himmatnagar to chair this session. And today's speaker is Dr. Shashank Joshi sir from Mumbai. I would like to say chairperson to introduce the speaker and continue the session.
There's a lot of echo in your talk.
Hi, good afternoon, everybody. I think after the eclipse, all of us have come in a new shape. And I've got a privilege and honor to introduce Dr. Shashank Joshi, sir, who is, I follow him very thoroughly, closely, and I literally adore him. And the other person is Dr. Ramchandran, sir, who is also in the frame. And it's my privilege and honor, and I thank the opportunity for this. And Dr. Shashank Joshi, for a change, is going to talk on diabetes today, apart from COVID, because you've seen him in all channels, all newspapers about COVID, and he is the key person in Mumbai, as all of us know, who's handling the COVID situation, is in the task force. And currently, sir is a chair of IDF Southeast Asia, is a president of the Indian Academy of Diabetes, and also is involved in activities of ACE and is serving as a chairperson for its Indian chapter. And Shashank Joshi sir has been honored by the government of India with Padma Shri, that talks about it's icing on the cake. And in 2014, way back, and is a former president of Association of Physicians of India, Endocrine Society of India, and RSSDI, and All India Association of Advancing Research in Obesity, that's RO. And over to Shashank sir to talk about today's topic is optimizing the fundamental approach to cardio-renal metabolic risk in type 2 diabetes with main focus on the SGLT2 inhibitors. I think we heard enough from the afternoon, but it is from the horse's mouth we're going to have his pearls of wisdom today about SGLT2. Over to you, sir.
So, what I am going to talk today is that, we are in an era of cardiometabolic risk or cardio-renal metabolic risk. And the whole focus of type 2 diabetes management is all about SGLT2 inhibitors. And Professor Ramchandran is here, my good friend Srinivas Murthy is here from Bengaluru. Parikshit is my other friend from Himmatnagar. Thank you so much. And what I'm going to do is discuss a few cases, because I think it's becoming very boring to give didactic talks, and discuss some granularity of evidence. So from hope to disappointment has been the story of SGLT2 inhibitors. The disappointment was just last week with the ADA, where the Vertis CV turned out to be a damn squib and a disappointment. So it's not a class effect at all. I think that every SGLT2 inhibitor is different, and you need to really use the right inhibitor at the right time. I think these agents, SGLT2 inhibitors, do better in Indians compared to Caucasians. And I think one of the biggest drawbacks of Vertis CV was it was predominantly a Caucasian trial. And in Caucasians, I think some of these agents don't work very well. But that's my personal thinking. We all know this common cell hypothesis that diabetes is a vascular disease, glucotoxicity, lipotoxicity, inflammation, insulin resistance, endothelial dysfunction. It's one small conundrum. And in inflammation, the inflammasome, diabetic inflammasome, is all about kinases, transcription factors, pro-inflammatory factors, the ceramides, the pro-inflammatory signaling, which all come from the lipid pathway, the hexosamine pathway, and the pro-inflammatory signaling, and the age and oxidative stress from the glucotoxicity pathway. And 1 in 3 people have with diabetes have CVD. There's a global evidence. Atherosclerosis, 1 in 3 to 5 patients. Heart failure, 1 into 6 to 7 patients. In fact, we know that Ali Farnani gave a very wonderful talk just at the Banting lecture, that there is myocardial insulin resistance, and that is actually causing and driving that heart failure, which we see. And then, of course, we have the myocardial infarction and stroke, 1 in every 10 patients. So 1 in 10 have a stroke or a brain attack or a heart attack. Then 1 in 5 or 6 may have a heart failure or a myocardial stunning or a heart failure of diastolic dysfunction. And atherosclerosis coronary artery disease is seen in 1 in 3 or 1 in 5. Obviously, deaths are higher in our data, particularly in Asian Indians. Both Dr. Ramchandran and Dr. Mohan have published that consistently. And obviously, the older trials did not have a macrovascular impact, whether it was the UKPDS, Accord, Advance, VADT, none of them had the impact.
Sir, sorry to interrupt, your slides are not changing.
My slides are not changing, but I'm changing them here.
It is on first slide only. You have to click on enable editing on the top.
Enable
That yellow
editing.
line. You are seeing that yellow line, protected view.
I can't see any line.
On top of that, enable editing.
Enable editing किधर है? Your screening
Yeah.
side.
Tell me what you want
Yellow
to
bar.
do. उसके नीचे. Tell me what you want to do. उसके नीचे.
Tell me.
What you want to do.
There is screen. You are screen sharing. Stop share. New share.
Sir, you stop share and again reshare, sir. Stop
Okay,
share.
I'll stop share and reshare. That's better. You feel okay? I'll let me do that.
Yes, sir.
Now I go back and I go back to this and I share here, right? Acha, there I share. I say share a computer sound or optimize screen sharing.
That is not required, sir. If there is no video, that is not required.
So now I've shared it again. Can you see it?
Yeah. Now on
enable
the side,
editing.
yes.
Yeah, that one, sir.
Yeah.
Click on that, sir.
Okay.
Then just put it on slideshow.
Slideshow.
Okay. Can you see my slides now?
Yes, sir.
Yes, sir. Yes, sorry.
Done.
Thank
So
you.
I have already covered this.
Yeah.
And so, you know, the older trials, the big large trials showed that glycemic control really did not impact macrovascular health. And that's something again well known. But these three new age agents, you know, SGLT2 inhibitors, GLP-1 receptor agents, and gliptins. I think gliptins were a damn squib. They are CV neutral at best, and they should be avoided in heart failure. Maybe there could be exceptions like sitagliptin, but you know that's something which we know. GLP-1 agents are great agents, but they have their own challenges. And SGLT2 inhibitors have gone beyond endocrinology and diabetology. They have gone to the cardiologist, they have gone to the nephrologist. So they have a cardio-renal metabolic impact. So let us look at a case. An Indian patient with type 2 diabetes with subclinical coronary artery disease, 52-year-old male non-smoker, type 2 diabetes for 3 years, hypertension for 9 years, moderately active lifestyle, a BMI of 26, blood pressure 130/86, metformin 1.5 grams, telmisartan 80 mg OD, amlodipine 10 milligrams, atorvastatin 10 milligrams, A1C 7.8, which is very typical, which we see every day, and typically, fasting 154 pp, 238. The GFR is good, UACR is good, lipids show 191, total cholesterol, stress test is positive, angio shows a 50% lesion in the left main coronary artery disease. Typically, this is what we see. So, you know, what is the current guidance on ESC, ESD? Routine assessment should be done for microalbuminuria in all people, because we want to prevent something called as a early renal loss, and a resting ECG for all diabetic patients with hypertension or suspected CV. The level of evidence and class of evidence is B or C, but level is 1. Okay, and then try to assess carotid IMT, CT angio, a coronary angio, or a ankle brachial index, or a plaque, or even doing a functional imaging, which is radionuclear. So there the level of evidence is 2. And then of course, routine biomarkers, risk scores, the level of evidence is 3. That's how things are. And if you look at the current 2020 algorithm of ACE, you know, SGLT2 inhibitors are virtually there everywhere. Whether it's entry level of A1C of below 7.5, or whether it is at between 7.5 or 9, or even above 9. Of course, above 9, our first option is to settle glucotoxicity with insulin and then move them to an SGLT2 inhibitor or a GLP-1 receptor agent. So what are the cardiometabolic risk factors when we look at all the agents? Well, all of them control, excuse me, all of them control glycemia. Sulfonylureas have a late limiting step of hypoglycemia. Metformin is weight neutral, SGLT2 is weight loss, gliptins are weight neutral, and glitazones cause weight gain, sulfonylureas cause weight gain. Blood pressure impact is seen with bio and SGLT2. Lipid biology is having some impact with SGLT2 and pioglitazone. So if you look at glycemic control, no hypoglycemia, weight loss, blood pressure lowering, lipid impact, it's SGLT2 all the way. And we have that data. Now, this is data of EMPA versus SITA head-to-head, clearly showing that efficacy-wise, A1C reduction is better. It's doubly that potent of the gliptin, or at least in the US world. When we look at the classical study of EMPA versus glimepiride, which was observed at the ADA. Clearly, you can see the weight loss of empagliflozin is clearly maintained over 4 years. So it's a durable and sustainable effect of weight loss. The difference was 5 kilograms. That's huge when it comes down to database. And it also improves beta cell function. When you look at insulin secretion, insulin resistance index, or the disposition index, EMPA starts improving insulin resistance and deburdens, I call it deburdening the beta cells as early, and this is differential slide, as the second day to 14th day. That's a very quick and a fast effect. And also the empagliflozin has been shown very clearly that it decreases insulin resistance, decreases inflammation. Inflammation is decreased almost to the tune of 54%, and insulin resistance almost to the tune of 42%. And clearly it has an impact on nocturnal uncontrolled hypertension. Empagliflozin has been shown in the SARCA study that the nighttime blood pressure, daytime blood pressure, 24-hour blood pressure is consistently decreased in the study, and the nocturnal uncontrolled hypertension, the morning home blood pressure reduction is consistent. We know cardiovascular death, hospitalization for heart failure, and all-cause death is clearly decreased in this ratio, and clearly we can see that this granularity of the EMPA-REG outcome started very, very early. The graph and the curve moved out very early. And this is the only probably SGLT2 inhibitor which has a sustained reduction in CV death. And it's a 38% reduction in CV death. And if you look at all categories of CV death, the reduction is consistent in the EMPA category of EMPA-REG. And it's statistically significant. Fatal MI, fatal stroke, heart failure related death, sudden death, presumed CV death. Consistent linearity and granularity of a positive relationship. So it's consistently reducing CV death independent of with or without a prior CV event, and that was the data. And when you look at the MACE of SGLT2 CVOTs in type 2 diabetes, EMPA can reduce MACE in CVD, very clear data, and we know that the declarative could not have an impact on MACE, and clearly we have seen what is CV also not having an impact on death. And only empagliflozin, if you look at all the CVOTs again, reduce CV death. Neither declarative nor canvas could do that. So clearly the data is 38%, and the data for declare and canvas is no. And when we look at what is CV and EMPA-REG population, it's the same population. It's identical population. And actually what is CV had more patients than EMPA-REG, and absolutely the same. You can actually mirror impose them. If you see both the patients, very, very similar. Actually, what is CV had 23% more patients in heart failure or history of heart failure. And mean eGFR is same, and everything else was very, very similar on the trials. And again, if you see the benefits, what is CV clearly failed. 3-point MACE, non-inferior to placebo. CV death or heart failure superiority not demonstrated. CV death superiority not demonstrated. Renal composite superiority not demonstrated. And HHF nominal superiority was observed, which was an exploratory endpoint. So clearly, if you can now see on CV death, only empagliflozin showed reduction on CV death. Canvas has an hazard ratio of 0.86, and declared TB has hazard ratio of 0.94. What is CV of 0.92? So clearly you can see, but of course everybody is on the left compared to placebo. So they are neutral while EMPA-REG is positive. So that's very, very clear cut, which is there. So it's not really a class effect. And if you look at the ADA standards of care, okay, clearly if there is an atherosclerotic vascular disease, CKD heart failure, it's clearly an SGLT2 inhibitor, even preferentially over GLP-1 agents, because for CKD, the GLP-1 receptor agonists have their own challenges. And if you look at therapeutic choices, they have put in the hierarchical preference really for CV effects, for atherosclerotic vascular disease, heart failure, DKD, you know, EMPA at the top, followed by CANA, and that's something which is very, very clear cut. And of course, the black box warning are there for some of these agents as well. So clearly, there is that clear-cut impact of CANA. Let's look at the second case. That was about the first case. So I don't have a doubt that addition of EMPA in that patient would have worked. Let's look at case number 2. Case number 2 is a patient with type 2 diabetes with high risk of heart failure, 60-year-old female, type 2 diabetes for 1 year, hypertension 10 years, stable angina pectoris for 3 years, non-smoker, BMI of 26, blood pressure okay, metformin 1.5 grams, telmisartan 80, amlodipine 10, rosuvastatin 20, aspirin 325 is a high dose. A1C is 8%, fasting PP is high, creat is normal, EGFR, USCR is okay, USCR is 150, the LDL is 86, and pro-BNP is 150, LV mass is increased, LV volume and function is normal. So there is a clear-cut cardio-renal syndrome in this patient. And clearly you know that diabetes causes organ damage and dysfunction, from heart failure to renal insufficiency. And it's all a conglomeration of sympathetic overactivation, neurohormonal stress and inflammation, hemodynamic changes of hypoperfusion, decreased perfusion pressure, increased renal vascular resistance, ischemia and perfusion, hypoxia, oxidative stress, toxemia, and heme proteins, and the contrast media and the endotoxins. So clearly, when you look at heart failure, either we have non-acute onset suspected heart failure, clinical history, physical examination, ECG, and NT-proBNP or BNP, and echo. And that's how we really look at heart failure pickup. And we know the stages of heart failure. Stage A is high risk of heart failure, but no structural heart disease or symptoms. B is structural heart disease without symptoms or signs. C is structural heart disease with prior or current symptoms of heart failure. And D is refractory heart failure needing interventions. And when you look at LV mass index, which is what this patient had, we have this clear-cut data by Subodh Verma, who's a cardiac surgeon from Canada, clearly showing that the LV mass regresses in the IMPART study in stable CAD, which is what this patient had, this woman had, by 2.6, statistically significant, and that regression is very clearly. So IMPART was the first confirmatory LV mass regression with SGLT2 inhibitor in people with type 2 diabetes with CAD, majority without a heart failure. Most study participants did not have heart failure. The LV salutary effects were a probable cardiac benefit of CAD without cardiac heart failure. And the regression was observed as early within 6 months. And it was not dependent on preload or afterload. It was not dependent on the volume, or it was not dependent on 24-hour blood pressure. It was an effect directly on the LV myocardium. And then the other thing is OSA. And this is the data which was just presented by Needland et al. At the 80th annual conference just this week, which ended, that the new onset OSA clearly in type 2 diabetic patients with established CVD, EMPA reduced the incidence of OSA by 52%. Again, a great impact which we can see. And also when we predict risk of hospitalization or heart failure in type 2 diabetes, if you look at the TB risk score, and if you look at the TB risk score for heart failure and type 2 diabetes, and if you plot it as low risk, intermediate risk, high risk, or very high risk, clearly you can see that the data is clear cut, and the granularity of the data, both on heart failure, atrial fibrillation, coronary artery disease, EGFR, or urinary albumin to creatinine ratio is positive. So our prototype patient had stable angina pectoris and elevated UACR. And obviously, the data for that prototype patient clearly shows that empagliflozin will reduce all-cause mortality, CV death, or hospitalization for heart failure. And that data has consistently been shown. And it is consistent with or without prior heart failure is what the data says. And if you compare it head-to-head in a routine care setting versus sitagliptin, again, the data has a clear-cut hazard ratio, as was seen in the EMPA-RISE study, which was a real-world evidence study in this direction. So if you compare the effectiveness outcomes, clearly from EMPA-RISE, you can see a 48% reduced risk reduction and a mortality benefit, which is obvious. And the kidney benefits and kidney outcomes of SGLT2 inhibitors are very clear-cut. I think there is no uniformity. If you look at Credence data, the Canvas Declare and EMPA-REG data, very good and nice data to show the renal benefits. And again, here you can see the Scandinavian renal world evidence, which shows clearly the separation of the curves by Pastermark et al. Has very clearly shown that there is a 58% lower risk of serious renal events compared to a gliptin from that study with SGLT2 inhibitors. So that led in last year, the European Society of Cardiology and European Association of Study of Diabetes to show that in drug-naive patients, in patients with high risk CV risk or atherosclerotic vascular disease, start de novo SGLT2 inhibitors or a GLP-1 receptor agent. And that is now clearly a standard of there, or sometimes you have metformin. So clearly up the pecking order, class 1 level A evidence is available for EMPA, clearly showing that they are clearly death. But even when it comes to type 2 diabetes with CV to reduce risk of death, EMPA is right up there in the pecking order. So very clear data, very clear evidence, which is having strong evidence. GLP-1 also competes with the same evidence with liraglutide particularly. Biguanides are right there and they are at level 2. Insulin is also at level 2, but the level of evidence is C. So very clearly the data is, verdict is very clear cut. And if you look at the class of recommendation, it is class 1 recommendation for reducing risk of hospitalization and heart failure. So obviously I'm going to stop here. I'm just going to give you some pearls of wisdom for best benefits for SGLT2 inhibitors. Well, don't use these SGLT2 inhibitors if there's moderate to severe CKD, because below maybe the lower GFR, the real effect is lost. In pregnant breastfeeding movement, we don't know the risk. In hospitalized acute situations, severe illness and surgeries, there's a risk of euglycemic decay. Insulinemic conditions without sufficient insulin, there's a risk of decay. When there's volume depletion like frail elderly, loop diuretics, dehydration, renal impairment, monitor volume and hydration, complicated UTIs, discontinue them, recurrent UTIs, counsel caution, improper genital hygiene, counsel, and if there is fasting, starvation, dehydration, be careful. And with insulin secretagogues, you might get hypoglycemia and titrate the dose. So my last slide is, when your heart disease, heart failure, as CVD diabetes, it is a dual jeopardy. Holistic approach is cardio-metabolic and renal risk. And in that personalized approach guideline, I think SGLT2 inhibitors should be a standard of care for people with atherosclerotic CVD or heart failure and diabetes. EMPA has some outstanding benefits. When you look at the conundrum of trials, it stands out as a level of evidence is very high. And the EMPAREC trial, which was the first trial to be out, continues to be a surprise to us and continues to be an enigma. But the evidence which has been built over empagliflozin for the last 5 years is reasonably compelling to make us say that it is cardioprotective and renoprotective. It is cardiopreventive and renoprotective in this cardio-renal diabetic situation which we are facing every day. But it's all about individualization. It's all about risk-benefit ratio for that individual patient. And that's where we are. Thank you for a patient hearing. And thank you for Dr. Sabu for giving me this opportunity to talk in this symposium. Thank you.
Thank you, sir, for timely completing. I request Dr. Parikshit, my co-chair, to take over.
Yeah, it's a wonderful talk. Every time Dr. Shashank, once he will speak, he will throw the different lights to the same topic. And my question to Dr. Shashank sir is that although the trial population for Vertis CV is more or less similar with the EMPAREC trial, what could be the reason for not having a better outcome in terms of mass and the CV death?
So the honest answer is we asked the same question to Dr. Franzo yesterday, and he says he doesn't know. If you ask me, I would say I don't know. But I'll tell you my take on it. All the other trials had Asian populations, while Vertis CV did not have the Indian cohort. There was a person from Middle East who wrote a very nice paper that from the EMPAREC trial, if you take out the Asian population, then the Caucasian population, the results are neutral. So actually, I think it's the Asian population where the influence of EMPA is very pronounced and Vertis CV is not at all pronounced. Second thing is, I think it's disappointing because they couldn't meet virtually any endpoint except maybe marginal renal endpoint, and they met the HHF endpoint. So that is the exploratory endpoint. They met it, but clearly it distinguishes that Cana was little too powerful. They had that outlier of amputation, but we still don't know why Credence was having that little renal edge for Cana. But EMPA is consistent, and DAPA didn't make the 3-point MACE at all. So they have that little limitation there. They are piggybacking on the heart failure issue, and Vertis CV probably has just not made the cut. So I think there is some subtle difference in each of the SGLT2 inhibitors, and that's what evidence is saying. So I'm not saying that this is my hypothesis. That's what. There's a poll question. You would like to take the poll question?
Yeah.
Yes, sir. We can have a poll question.
Yeah.
Yeah. So,
meanwhile, Dr. Ramchandran sir, any your thoughts on this, sir? Vertis CV?
Yeah, I think what Shashank said was that if you look at the forest plot of different ethnicities, we found that in the cardiovascular outcome with EMPA, the Caucasian population, North American population did not do so well as Asian populations. So there may be some differences in the ethnicity or when the recruitment has done, and that may be one of the reasons. But the real, honest, sincere answer is that we do not know why this has happened. What is there a difference in the mechanism of action between these SGLT inhibitors? We do not know. So a trial will show you the clinical effects and give you proof, but it will not give you the mechanistic explanation.
Thank you, sir.
Okay.